So
much.
the next session.
Thank you.
Next session is on peripheral vascular disease, abdominal aortic aneurysm. And for the session, we have chairperson Dr. Kamath, Dr. Tarun Madan, Dr. Jignesh Kothari. We have moderators Dr. Benny Jose, Dr. Pramesh Gaidane, and Dr. Manish Juneja. Over to chair to introduce our two speakers, Anoop Gupta and Dr. Vishal Gupta for the session. Over to chair. Dr. Tarun, Dr. Jignesh. Dr. Benny, Dr. Pramesh, you can go ahead and introduce our speakers. This is the case. Please read the case and introduce the speakers. You need to unmute.
Good morning, everybody. We will be discussing a peripheral vascular case. This case, 55-year-old male with large saccular aortic aneurysm, abdominal aneurysm with the size of 8 by 12 by 11 centimeter, having partial thrombus along with ongoing abdominal angina and right renal artery and inferior mesentric artery arising from the same. So we are having good speakers, and the blue corner will be for Dr. Anoop Gupta sir, who will be discussing EVAR with side branch protection, and the red corner will be for Dr. Vishal Gupta sir, who will be speaking on the surgical endograft. So I think Dr. Anoop Gupta sir can start the session. Dr. Anoop Gupta sir.
Yeah, thank you very much. Let me share my screen and tell me when we are able to see it or not.
Yeah, to have more discussion, I think we are skipping and having a less introduction.
Can you see my slides now?
Yes, sir. It is visible.
Perfect. Thanks, Kamal, for inviting me to deliver talk in your conference. Going pretty good. And at the same time, putting against Vishal, they are feeding these cases to us. So, debating with the surgeon for EVAR is always a difficult thing. So again, the age which has been given is 55-year-old, neither falls into an older age or neither falls into a young age. It's a middle age. So it's a very debatable thing. So what should the preference? So coming to the abdominal aortic aneurysm, most common location. In fact, in a day-to-day practice, we often see more thoracic aortic aneurysm, which we treat, but the incidence of abdominal aortic aneurysm is more. And normally what they say, if it is more than 3 centimeter or more than 50% of the abdominal aorta origin at the level of T12, what we say is an aneurysm. And most important thing, whether the patient is symptomatic or not, and what is the growth. If the growth is more than 1 centimeter, definitely we try to intervene those patients early. Otherwise, when it is a symptomatic patient, in that situation, we normally treat those patients. So the risk factor, there are certain risk factors, and we know these risk factors. The most important is the age. In this patient, the age 55. So, 55 falls right in between. So that is very, very important. Other thing is atherosclerosis, how much the atherosclerosis, how much the peripheral vascular disease. Then again, it goes into the decision whether you want to do an EVAR or you want to send the patient for surgery. So what are the recommendations? The 3 recommendations, the strong recommendation is persistent ruptured aneurysm is 1. If the dimension is more than 55 millimeter, that is again a level of indication is A. And if the patient is symptomatic, in that situation, again, the level of recommendation is 1 level. So these are the 3 situations where definitely you will subject the patient either for EVAR or surgical. So the most important thing is, these patients are detected normally in ultrasound when people goes for abdominal pain for CT angiography. For abdominal pain. And the most important thing is CT angiography prior to the procedure. That gives you a lot of information, like which are the side vessels involved, what is the extension of the aneurysm, whether the renals are involved or not, what are the status of the iliac arteries. MR angio we don't perform quite often for abdominal aortic aneurysm, the reason being more expensive. And conventional aortogram, again, this doesn't give a lot of dye involved. So these patients are sick, so we don't want to give dye in these patients. So what is more important when you are performing an EVAR? There are 3 things. One is the neck. The other is the morphology. Again, the morphology, which all vessels are coming from the aneurysm. And third most important thing is the iliac artery anatomy. So these are the 3 things, and these 3 things are normally addressed in CT angio. So most of the patient until it's a ruptured and patient is in a shock and you don't have any time to perform a CT angio and you're taking for surgery, it's an exception. Otherwise, we will prefer to perform a CT angiogram prior to taking all the patient for EVAR. So this is how the neck is defined. Like, you put two perpendicular lines. Yeah, two perpendicular lines and then see the angle. So this is the aortic neck is very, very important because of the delivery of the device, the deployment. You want to exclude the aneurysm also. And you, at the same time, you want to have a very long-term durability. So what is more important for the neck is the length and the angle. Whether there's any calcification inside the neck or there's any thrombus inside the neck, then again, it is very, very important. There are three kinds of neck which has been described. One is straight, other is tapered, and the reverse tapered. When we call it the reverse tapered, it means that there should be difference of more than 3 centimeters in the proximal and the distal part. So we are quite comfortable when we have an aortic neck of more than 15 millimeter with a very wider aortic angle and there's no calcification thrombus. These are the subset where we think that, we are quite okay. And now what Kamal has given, like, in this patient, the right renal is involved, the inferior mesentric involved. Inferior mesentric, we are not worried about the thing, but right renal, yes, we are very, very worried about the thing. So aneurysmal angle, if it's a very, very small angle, the delivery of the stent graft and deployment becomes very difficult. It is not precise. And sometimes you land up in a type 1 endo leak and you have to deploy another graft stent. And in our country, like, putting 2 graft stents, then it is a very, very difficult thing. Presence of intramural thrombus, again, it increases a lot of cardiovascular events. It can progress rupture. And these are the arteries, like, again, inferior mesenteric artery, lumbar, and the sacral artery. So lumbar artery and sacral artery, even for the surgeons to re-implant these arteries are very, very difficult. So obviously, if you see more prominent, more than 2 millimeter of lumbar arteries in those situations, you can definitely coil these lumbar arteries also. And suppose if you have an internal iliac, which again, you feel like, you're going to give it trouble. So, you can do a stage, like, you do a coiling in the internal iliac, take the patient back after a day or maybe 2 days, and then you can deploy the thing. Inferior mesenteric artery, again, the size, if it is more than 3 centimeter in that situation, obviously you are going to coil to prevent type 2 endo leak, because this is the thing which really trouble when you're performing an EVAR patient. So the third thing, iliac and the common femoral. So the distal aorta at the bifurcation should be more than 20 millimeters, the tortuosity and the diameter, and whether there's any atherosclerotic reason. And I tell you, take my word, like, most of the patient, these patients, they have got a very bad atherosclerosis in common iliac arteries also, and even in femoral arteries also. So that sometimes gives you a lot of trouble to push your stent inside the aorta. And the length of the common iliac artery and the tortuosity is very, very important. So whenever we say the index of more than 1.6, it says that, it is very, very tortuous. And when you put a graft stent, it is always better to enhance the graft stent with the metal stent for the patency of the iliac. So according to the CT angio, you are going to select which one you really want to see, whether you want a suprarenal fixator or an infrarenal fixator. The suprarenal fixators, or you will see all three ABC, they will have a bare metal strut which can anchor the thing, and infrarenal fixators, they don't have any bare metal stent in the proximal part. And it could be exoskeleton, means the skeleton is on the outside, A, B, and E, or it could be endoskeletal. So the advantage of endoskeletal is the arterial stiffness, because again, long term, you have to see what is the long term, because this is a relatively young patient, 55. So, you have to see what is the long term effect on the arterial stiffness. So probably I would say endoskeletal will be much better option in this patient. So what is the technique planning? What I said, CT angio, that is the most important thing. Arterial access, we don't, the thing is that if it's a surgeon, surgeon come for a cut down, otherwise we don't need, because we can use ProGlide, and it's what we call it now, we call it PEVAR. We don't have to make any cut down at all. And if the mesenteric artery more than 3 millimeter or the lumbar artery more than 2 millimeter, in those situations, you will embolize those arteries first. And internal iliac artery, again, how much the graft length is going to come and cover the internal iliac artery, and whether there's any aneurysm over there or not. That's more important. Coming to the particular patient, probably we'll go for this chimney technique, or we are going to make a fenestrated graft so that to protect the right renal artery, because I'm not more concerned about the inferior mesenteric artery, which definitely we can coil it, or you can order for a customized stent graft in this patient if the patient is relatively stable, and you can take after 3 days or 4 days or 5 days. So this is how it looks like. This is a simple anatomy. Like, both the renals are spared and
Time is up.
large. Oh, okay. I'll finish my talk in one or two slides. So again, this is the coiling, and this is like, what we call a reverse chimney in the renal artery. So the complication, what I said, is the endoleak, and endoleak I'm not going to discuss more. What are the advantage? Without general anesthesia, under local anesthesia, average stay 2 to 3 days, mortality is less, both in hospital and at the 30 days. And if you see the surgical mortality, it's definitely higher than what the mortality of the EVAR. So the take-home message, PEVAR is treatment of choice in this patient. Most importantly, you have to understand the anatomical feature, adequate planning, and performing the essential ancillary procedures, and selection of the appropriate devices. I'll stop here and let Vishal to take over. Thank you very much.
Over to Chair to introduce our next speaker. Please unmute yourself. Dr. Tarun, you can.
Yeah. Thank you, Kamal Bhai, for a lovely conference. Vishal Bhai, good morning, and I invite you to give your presentation. Dr. Vishal Gupta is a senior cardiovascular thoracic surgeon in Ahmedabad.
Okay, should I start?
Yes, please.
Yeah, thank you very much, Kamal, for this warm invitation. And as Dr. Anoop Bhai very rightly said, that we are on these cases together most of the times. So debating against Dr. Anoop on this thing is a little awkward, but let us just present our points in favor of the subject that has been allotted. That patient is a 55-year-old guy who was an infrarenal aortic aneurysm. What would be the treatment strategy? Being a surgeon, I would like to defend surgery for this particular patient. I will not get into details of abdominal aortic aneurysm because that has been covered by Dr. Anoop. It's when the size of the aorta in the infrarenal segment goes more than 1.5 times normal, that is, it's more than 3 centimeters, that an abdominal aortic aneurysm will be detected. And most of the times these patients remain asymptomatic, and as he rightly mentioned, for an ultrasound, for some other reason, these aneurysms are detected. And most of them are in the infrarenal aorta, and only 5% of these infrarenal aortic aneurysms could be juxta-renal involving the renal arteries. And 75%, as I said, are incidental and asymptomatic. And the normal expansion rate for these aneurysms would be 0.5 centimeter in year, and eventually they would rupture. And once these ruptures, the mortality rate is very high. 50% of these patients don't make it to the hospital. And even of those 50 that make to the hospital, the mortality is close to 80%. So if untreated, these, as you can see from the slide, that aneurysm, which is 5 to 6 centimeter, by 5 years, 25% of them will rupture, and which are more than 7 centimeter, 75% of these aneurysms are likely to rupture in the course of next 5 years. So this is, once the AAA is diagnosed, this is how we would go about it. If the aneurysm is less than 4, we monitor them annually. And if it is more than 5, but less than 5, we monitor them every 6 months. But any aneurysm which is more than 5, 5.5, or symptomatic, or growing by more than 1 centimeter per year, endovascular or surgical management should be given. So as has already been discussed, there are 2 surgical options for these patients, either open or endovascular. Open surgeries can be done by 2 approaches. One can be trans-abdominal approach, and the other one is retroperitoneal approach. So trans-abdominal approach, the advantage is we get clear access to the iliacs, because in quite a number of these patients, the iliacs are also involved. So we would get total control of the distal and proximal segment, and especially in the patient that has been the subject of this talk, this is the renal. So trans-abdominal approach is always beneficial because of the suprarenal control of the aorta. So this is how we isolate the aorta at the level of crux of diaphragm. So where we separate the crural fibers of the diaphragm to put a clamp at the suprarenal aorta. And as far as the renal arteries are concerned, the renal arteries, once you isolate the aneurysm and you put the graft inside, then the renal arteries can be implanted either with Carroll technique with a cuff of aorta around them, or we can put an interposition vein graft to the renal artery to do the same. And this is how an end result of open surgery would look at the end of the procedure. So the advantages of open surgery would be, it is a very established procedure, and the first procedure was done way back in 1953 with more than 40 years of clinical experience, and it totally excludes the aneurysm and prevents sac growth, which unfortunately is not the case with stent grafts, and the incidence of later sac ruptures or reinterventions become very high because those components are not addressed with an endovascular repair. So it has proven long-term results. Yes, there are some drawbacks with the open surgery. I would not deny that. Patient will have a big incision in the abdomen. The cross clamp time could be anywhere between 30 to 90 minutes, depending upon the skill of the operator. And the procedure would last around 4 hours. And it has some very strong contraindications, like patients who are bad anesthesia risks from cardiac point of view, patients who have renal dysfunction, patients with bad lungs. These are a subset of patients we would like to do surgery with a very pinch of salt, because it is, the mortality can be higher, right? And patients will require to be hospitalized for about 5 to 10 days, and the recovery time would be approximately 6 to 8 weeks. So as we can see from this slide, any patient who's less than 70 years and who is a very active person otherwise, with no cardiac, pulmonary, renal or other abnormalities, the anticipated operative mortality is in the range of 1 to 3% with good open surgery. So I think more than patient preference, appropriate anatomical criteria are critical in deciding whether the patient needs to be subjected to an open surgical repair or an endovascular in young patients, right? As Anoop is already mentioned, these are very important criteria, like the aortic neck diameter, right, which has to be approximately 18 to 30 millimeter. And this is required because most of the times when we put an endovascular stent, you increase it by 15 to 20% so that it gives sufficient radial force to prevent device migration. So the aortic neck length, this is also very important. It's the distance from the lowest renal arteries to the origin of aneurysm, should be at least 10 to 15 millimeter to provide an adequate proximal landing zone for endograft fixation. Neck angulation again becomes a very important point in these patients. It's the angle formed between 3 points connecting the lowest renal artery, the origin of aneurysm, and the bifurcation. Ideally, it should be less than 60. Angles which are more than 60 can lead to difficulties in implantation, kinking, endo leak, and potential for device migration. So this is the ideal situation for endograft. But now the complications with EVAR, they can be related to the deployment, device related, and implant related. Won't go into details of deployment related like bleeding, hematoma, but device related structural failures are common. Implant related endo leaks are one of the commonest complications with endovascular repair, sac enlargement, stent migration, AAA rupture, infection. These are the different types of endo leaks. Would not like to get into details, but these are common complications of endovascular. But in skilled hands like Dr. Anoop, we usually don't come across such complications in our patients. So whenever you are making a choice in a young patient with endovascular, we have to weigh the long-term benefits, the durability of procedure, like the risk of device-related complications, the cost effectiveness, re-interventions, and radiation exposure. There are studies which suggest that beyond 8 years, the risk of cancers in patients with endovascular. These are some of the trials, like EVAR1 was the first trial which enrolled 1,252 patients, which shows a rate of complication in these patients approximately 40%, and the rate of re-intervention as 20% compared to 6 compared to open surgery. This is again EVAR2 trial. DREAM trial is a Dutch trial comparing open with endovascular, which shows that re-intervention rates at the end of 4 to 8 years is significantly higher with endovascular And the only re-intervention for open surgery was for incisional hernia.
Sir, time is up.
Yes. So these are various trials. So I would conclude by saying that anatomical suitability for EVAR is proxy for subsequent complications. So the anatomical suitability with high-grade 3D CT scans, we really have to check the feasibility of EVAR for any patient. And the rate of re-intervention continues to increase with time, regardless of the device, with the newer devices as well. So the compliance with EVAR device guidelines are far too liberal. Industrial interests, demand and supply. So patients with acceptable operative risk and longer life expectancy are best candidates for open repair. And high-risk patients with marginal anatomical suitability or short-term life expectancy will not benefit much from EVAR, as has been shown in the OVER trial. And early repairs of small aneurysms does not give any advantage over surveillance. So whilst the overall management of abdominal aortic aneurysms has undoubtedly benefited from the introduction of stent grafts, open repair, currently looking at the age of the patient, because all the trials have enrolled patients who are more than 70 years of age. So we really don't have very long-term data on younger patients as how these patients are going to behave with an endovascular 10 to 15 years down the line. So also end of the talk, I would like to say in times of schemes like Maha Yojana and Ayushman Bharat, open surgery still stands a chance against endovascular. But yes, of course, surgeons need to have good experience. Any center which is doing close to 30, 40 open aneurysm repairs would be considered fit and with good results should be given a preference. Thank you.
Hello. Hello.
Yes, sir, you are audible. Yeah.
Yeah, both the participants, I think they have presented their views. And I think the given scenario which was given in the presentation was a 55-year-old saccular with the inferior mesentric and right renal artery coming out of that aneurysm. I think inferior mesentric artery can be sacrificed, and as Anoop sir has already mentioned, fenestrated device or a chimney for the right renal would be a good option. Though the case is hypothetical, right renal artery arising from the aneurysm and left renal is spared, which is practically unusual.
Very unlikely.
Very unlikely that both the renal arteries are more or less at the same.
I wanted Tarun to give some leverage to debate. Otherwise, if I was to involve both the renals, then probably surgically there would not be.
I think given the scenario, the fenestrated device or the chimney for the right renal, embolization of inferior mesentric would be a suitable option. But then, as Vishal sir has already mentioned, we are not being provided with the angulation, neck, and the other details. So I think looking at the case-based scenario, in some cases where the neck is really angulated, calcified, then the open surgical repair stands an edge above the fenestrated repair. But given the scenario which is being presented here, the fenestrated and endovascular repair, or PEVAR, as mentioned by Anoop sir, would be the preferred mode of treatment. Anoop sir.
Yeah, I agree with you. Like, means it was a difficult scenario. What Kamal said, like, right renal, I've never seen in my life, like right renal coming below the left renal.
Yes.
Very clear. So the thing is that, means there are so many logistic things that we are talking during the conferences about the science, what is good for the patient. But here there's a lot of logistic things are there. So the logistic things definitely like convincing the patient, the finance, and then, means suppose you land up with, instead of one, you land up in 2 grafts, then again it's a problem. But 55-year-old for Indian scenario, probably I will still go for a PEVAR rather than an open surgical repair. If it is a 45-year-old man, probably I will subject for surgery for a long-term better result. But yes, my preference would be in this. And fenestration, if I can get a fenestration, I will prefer that rather than putting one more covered stent, or inside the covered, there's one more bare metal stent for the renal chimney. So fenestration, I will prefer to that. And inferior mesenteric is not an issue, that you can always coil it. That's not an issue.
So I think fenestrations are the better mode of treatment. And sometimes if the fenestration is not possible, people have advocated making of scallops. and you can make a scallop in the superior most part of the stent graft, and through that scallop you can put a bare metal covered stent in the right renal artery, and then embolize the inferior mesenteric artery through the arm access. But then all said and done, out of these two modalities, we should choose what we are more experienced at. If we are more good at open surgical repair in the center, we should choose a open surgical repair rather than just doing an endovascular repair. If we are more accustomed and well versed with endovascular repair, then we should take up endovascular because it is less invasive, less morbid. The patient gets to walk out very quickly. And though the cost is an issue, but we are not discussing the cost here. We are discussing science over here. Kamal sir.
I completely agree with what you have said, Tarun. Keeping one renal here and there was just to bring to your notice that, of course, renals, we all know which one is higher and which one is lower. But at the request to make it a debatable thing, to keep some not defining the anatomy, landing zone, etc., was primarily driven so that everybody could discuss about those things, as to we not need to know more things just than knowing what is the size of the aneurysm, as was elucidated by both the speakers. Dr. Jignesh Kothari, your comments?
Yeah. We have a surgeon, Dr.
What I would like to say that this is a perfectly area that surgeons and cardiologists should combinedly make a decision. Rather than competing with each other, they should provide support to each other, because every time and this is the perfect area where both of them should understand their limitations rather than competing with each other, because every time there are pros and cons. And in the surgery also we have seen in a scenario where we are working, like there is a finance is a status, socioeconomic problem is a status, everything is a problematic. So better than both the cardiologist and surgeon should combine and make a decision rather than the clear-cut guideline that this patient should go for this and this patient should go for this. This may change from the institute to institute.
Fully agree, Dr. Jignesh. In fact, 95% of our patients are referred by surgeon only. So there's no, there's no competition. It's always a combined effort. Because these aneurysms, they go to surgeon. They never come to cardiologist at all, or even they don't.
It is other way around, sir. It is other way around, sir. We get preference from cardiologists only. They never come to surgeons. Basically, the cardiologists come to send patient to us. So it is basically mutual understanding and discussion is most important.
We have two other cardiologists on the panel, Dr. Pramesh and Dr. Manish. One by one, you can put your views also.
Yeah, sir, I think we are in the era of growing science, and what's the best for the patient, as you said, what's the best science we can provide to our patient matters most. So as the TAVI has grown, that in a very high risk and high risk patients, one goes with the TAVI, and in the stable and the intermediate patient, one goes with the SAVR. So I think the same things will come in this scenario also, where the mortality is high, the surgical risk is high in a ruptured aneurysm. EVAR will play a role in a patients where long-term benefits are needed. I think in that cases, the surgical repair will play a role. So it's a growing science, and I think the guidelines will come in the same way as that of the TAVI.
Dr. Manish.
Tarun, can I ask one question to Vishal?
Yeah, sure.
Now, see, the thing is, suppose you do a surgical repair in this patient. So, if you're putting a graft inside the aneurysm, so how you are going to isolate both the renals? You are going to re-implant that, or you're going to take your sutures like that, that the renals are not affected in this particular scenario?
See, in this type of situation, Anoop, we will put a suprarenal clamp, right? I can understand the renal ischemia during that time will be taken care of by mannitol, diuretics. We will do renal hypothermia by selectively cannulating with a 6 or 8 French fluid catheter into the renal artery and giving cold oxygenated blood. And once we are finished with the joint, then we implant the renal either with a cuff of aorta, and as you very rightly mentioned, aneurysms is just a debatable scenario where only the one renal is involved and the other is spared. Most of the times they are more or less at similar level. If you have an aneurysm at that particular position, both of them would be involved. But otherwise, we have to do all these renal protection strategies in the form of renal hypothermia, renal perfusion, diuretics, and mannitol. Then we have to implant this renal either with an intervening vein graft or directly the renal along with an aortic cuff on the graft. As well as if we feel like in this particular type of case, or rather in any infrarenal abdominal aortic aneurysm, the inferior mesentrics are involved. But if the inferior mesentric appears big, we clamp inferior mesentric at the time of surgery, see the perfusion in the color change in the bowel. So we have to check in the CT before surgery how the supply is, how the superior mesentric is. So if this, it appears high, if stump pressure of inferior mesentric is high, even that inferior mesentric we implant on the graft.
Okay.
Dr. Manish.
Yes, I fully agree with what Tarun sir and Kamal sir said. The both procedures have their advantages and disadvantages, the indications and contraindications. But it is better for the patient if the cardiologist and cardiac surgeon are on the same side of the table rather than debating these things. And it's very true that these practices vary from institute to institute. So if some institute is better at better experience at doing EVAR, then it is better to perform a EVAR, and likewise a surgical repair.
I would like to add, Anoop sir, if these kinds of scenarios are coming, see the distance between the superior mesenteric and the right renal is not very great. Majority of the time, this is around 12 to 13 millimeter. So it is always advisable if there is a juxtarenal aneurysm or the pararenal aneurysm like this scenario, we should always start the sealing zone from the celiac axis. So up to the extent that you may have to put 4 fenestrations, one for the left renal, right renal, superior mesenteric and celiac, and start the fixation zone from the supraceliac level, and then give a better seal rather than giving a temporary result and then later on within 6 months coming back with an endo leak.
Fully agree with you, Tarun. This is a very difficult, placement of the stent for this, it would be very difficult. You'll end up, and finally you will end up in putting 2 stents. So, what you said, I fully agree with you.
Yeah.
And if cost is a factor, visceral, retrograde, visceral debranching can be done. I agree with Tarun, can be done, followed by a stent graft in the segment.
Yeah, that is also a very good scenario in which you do a laparotomy, do a iliac to retrograde debranching.
Yeah, retrograde debranching you do, and then you put in the graft. That really serves the purpose.
And that makes the job very easy. Then you ligate the vessels and then
you because
close.
fenestration and it becomes complex. Yes, in trained hands, there is no problem at all. I totally agree.
So the time is up.
Yeah.
Okay. Thank you so much, all of you.